big Scandinavian studies, and it shows that the survival rate in terms of revision is really good at 10 years for cement. But if you look more carefully at his data, and this is one of the most quoted articles in the literature, look much more closely, the probability of a good or excellent result at 20 years is down around 50%. Something's going on here. And this is the Scandinavians that know how to cement. This graph is right in that Nilsson article, but nobody talks about that. And if you look at the pain, the chances of having a knee that isn't either moderately or severely painful is about 85%, okay, at 10 years. I mean, 15% of them hurt moderately or severely, and doesn't it suggest to you that something's going on? Ronawat. So his paper that's quoted by everybody, 1.5% loosening at 10 years and 6% loosening at 15 years. And that's Ronawat's chosen patients. That's a big difference, 1.5% and 6%. Something going on here, and if you look at his numbers, this is where it breaks. About 10 to 12 years, things start to fall off. These are his usual patients, osteoarthritic, rheumatoid arthritic, heavy patients. 100 kilograms is out of his bounds. So those are his heaviest patients, all right? So this represents what I would get if I were using cement. And this is both clinically and radiographically intact, okay? This is the survival, clinically and radiographically, about 70% out here at 15 years. 30% failure in the type of patients that I use, that I see and take care of, and my colleagues in St. Louis take care of. I'm seeing what's happening to their patients after 10 to 15 years. And certainly a lot of patients don't ever come back after their first month's visit. And a lot of them, when they get sore and painful, are getting kind of older and they're kind of being shoved aside. But if you look carefully at cemented joints, that's what's going on. And the more I look at it, the more I'm convinced I am that it's going to disappear from practice. It's still hanging on in the knee. And here is what is going on. Cementing to a porous bone interface has a fairly short lifespan. This is from Schmalzried's award-winning paper that he published in the early 90s about attack of the bone cement interface. I think, can you see that from there? This inflammatory edge worked its way all the way around this cement that's pressed into Cancell's bone. He was the first to start talking about that, but I never could get him to understand that he ought to quit cementing joints. He still does. Now this is by Mark Miller. You guys may have run across Mark Miller, very smart engineer sort of guy. And Claire Remnack, she's one of the authors as well. Very well known. What they did was retrieval. They did it in the hips and they did it in the knee, tibial component in the knee. And early on the retrieval during the first year, this is what that interface looked like between cement and bone. Of course, this is bone and the cement, and these are the bone trabeculae, deeply penetrated with cement. Okay, all those trabeculae are deeply penetrated with cement. Now, as time passes, what do you think is going to happen? Is the cement going to go away? Is the bone going to go away? Or are they going to both stay the same? Now, this being a biological interface, what do you think? Going to change? And if it does, what do you think is going to happen? And I bet you know, without even having read the article, this is what happens. The bone recedes because it's not stressed up in that cement matter. It starts to pull back. There's an inflammatory process, just like Schmalzried said, that works its way into there. And so after 2 years, this is what you see. This is a retrieval after 2 years. Very typical of what you see after 2 years. This is what you see at 10 years. Almost all the way across all these cemented tibias. That's where the bone used to be up into all these, oh, excuse me, that's where the cement, the bone used to be up into now the cement trabeculae. This is where the bone is now, and this is a dense fibrous interface. And I must say, every time I revise a knee that's been in 10 years or so, that's what I find. When I take it out, some people might say it's well fixed. What I find is a dense fibrous interface. And that's not all. The metal does not stick to the cement. Cement does not stick to metal. Just doesn't. I don't care what you do. It will stick to a porous metal surface. And when we first started developing porous metal surfaces, the excuse back in the 1980s was that it makes the cement bond to it better. And that's what we told the FDA auditor guys. This makes the cement bond better. And sure enough, it did. If you do the studies, you find that that bonded interface makes the whole composite much stronger. And if you debond one of those interfaces, everything breaks down. And this is a debonded interface. So this is from Michael Reese's study. And what he found was in these cases where cement looked pretty good, they were still getting osteolysis going on. And then these funny little gaps that he could see, and he was wondering what is going on. And of course, being a surgeon, he revised it and reported debonding. Not a big surprise. And this is one of my own cases. This was sent to me by a colleague. And I said, looks good to me. The cement mantle it looks excellent. And I wonder if it might be metal sensitivity. I've got a series that I've done on metal sensitivity and a ceramic femoral component. Maybe this is metal sensitivity, sent off all the bloods, and maybe a little bit reactive to nickel. And that was the X-ray. This was the tibial component. Okay. Now, what you get when you have a tibial component that's totally debonded like that is a kind of a hot bone scan. You put a needle in it, you get a bunch of macrophages in that fluid, and maybe a total of about 1,500 polys. This debonded interface is very uncomfortable, and it leads to breakdown of cement. So you can see that most of the cement's broken down, and so I start chipping that stuff off. And what I find is back into one place or two, maybe there's still a few bone trabeculae left, but this is a dense fibrous interface. And this is not dense fibrous, this is soft fibrous interface, and that cement mantle is breaking down as well. Look good on X-ray, and it would be classified in a study as radiographically and clinically still intact. So that's where I question a lot of these Swedish studies that use revision as an endpoint. I think that a lot of them have already failed. This is another patient referred with the same sort of clinical story. Started hurting about a year after surgery, kept hurting 7 years post-op, can't stand it anymore, got to do something. And that's the interface. Looked pretty good, cemented. That cement mantle, that's about all of it I could see. Not impressed by how much cement was in there. And this is the femoral coming off. No problem. By the way, the tibia was debonded as well. That's totally debonded interface. And the other surface, the cement surface, is not spared. When it debonds, the loads are huge in that, and then also the abrasion is huge. And here's the little chips of cement that are left. The little chips of cement are surrounded by a pretty soft fibrous tissue, and then that fibrous tissue is eroding bone, so a significant amount of bone loss in that case.